All right. So today we have the polytrauma pelvic fracture session as our first scenario for trauma section of critical care. Okay.
Okay, sir.
So this is your scenario. Kindly review it and then we will start.
Okay, sir. Yes, sir. I'm ready.
Okay. So what other sort of injuries would you suspect in this patient?
Um, sure. As seen in the X-ray, because there is a pubic diastasis, a widening of the pubic joint, and also sacroiliac disruption. Uh, yes, sir.
Okay. So how will you manage this condition?
Sir, the first thing that I will do is I will follow the ATLS approach of airway, breathing, circulation, disability, and exposure. So, would you like me to explain it?
Okay. So what is the first thing that you will do in this patient?
Check the airway. I will look, listen, and feel. I look for any signs of foreign body in the airway, and also I'll also look for the chest raise. And next, I listen for the internal airway obstruction. Um, then I will also um, in the I will insert an airway if the patient is having any sorry sir
Okay, that's fine. Okay, so assuming that the breathing is fine, what will you do to manage the circulation of this patient?
sir okay so regarding the circulation, first I will put two large IV bore cannulas, and I will start with IV fluid. For that, I will draw blood for the cross matching and blood grouping and RH typing. And I will also withdraw blood for some essential investigations like the test, renal function test, ABG, lactate. And I will also order for blood. And blood transfusion will be started in 1:1:1 ratio. Platelets and until the patient's vital signs improves normalizes.
Okay, so can you describe the X-ray which has been provided to you, the findings in this patient?
There appears to be a right neck of femur fracture along with a pubic diastasis and also a right sacroiliac joint disruption.
Okay, so what are the different types of pelvic fractures?
Different types of pelvic fractures are anteroposterior, lateral, and vertical fractures. In anteroposterior fracture, there will be three types. The first type is lessened diastasis along with a sacroiliac joint disruption. In the lateral fracture, there will be a fracture of the pubic bones and also unilateral or bilateral sacroiliac joint disruption along with disruption of more ligaments. And in the um, anterior lateral and in the vertical fracture, there will be fracture of the sacroiliac ligaments, the sacroiliac joint, and also the pubic bones.
Okay. So, given that the patient has hypovolemic shock, what will be the percentage of the blood that you will expect in this patient to have lost?
It will be more than shock.
How much percentage?
40%, sir.
Okay. So, how will you manage the hypovolemic shock in this patient?
Um, Sir, I will start with inserting two large bore IV cannulas. Um, and I will start with the investigations and for cross matching and blood grouping and typing.
Okay, so how will you monitor the response in this patient?
Sir, I will monitor the heart rate, the blood pressure, the urine output, refill time. So, in hypovolemic shock, the patient will be having tachycardia. So, I will look for the if the heart rate is getting reduced and the BP is improving and the capillary refill time is improving, the urine output is improving, or the patient's mental status is improving.
Okay. So, what does the blood on the urethral meatus signifies?
It signifies that there is a urethral injury, probably.
Okay, so what other urinary organ is most commonly injured in pelvic fracture?
Other commonly injured is urinary bladder and the kidneys.
And how will
Apart
you
from,
confirm that they are damaged?
sir, initially, if the patient is stable, we will go for a CT scan. The patient is not stable, we'll go for a fast scans.
Okay. So, what are the contraindications to Foley catheterization?
If there is a blood in the urethral meatus, it is a contraindication and an obvious pelvic fracture.
Okay. So, how will you manage and who will you involve in the management of this patient?
In this case, along with the anesthetist, the patient might require a intubation, uh, either endotracheal intubation, or the patient might require tracheostomy.
Okay. So, what are the other types of urinary catheters that you know?
Sorry, sir. I will also include the urologist in this.
Okay. So, what are the different types of urinary catheters?
Straight catheter, uh, suprapubic catheter, uh, Malakoff's catheter, condom catheter. Yeah, so
Okay. So,
three-way
what?
catheter.
Okay. So, what will be your management for the pelvic fracture?
Pelvic binder. I will give a pelvic binder to the patient so that it will uh, stop the internal bleeding if anything is there. It will give a compression effect. And then, if there is an ongoing hypotension, I will check for if there is any other injuries like in the chest, abdomen, or in the lower limb. And if there is an abdominal injury, that will be dealt with first along with external fixation of the pelvic fracture.
Okay, so anything else?
We'll do laparotomy if there is any abdominal injuries, like
Okay. So there are few mistakes that you did in this scenario. So in the
um,
first question, I asked that what other injuries you will suspect. So you just talked about the injuries which are apparent on the X-ray. So in this, there
oh,
could be a ruptured bladder, there could be a
okay,
renal injury, there could be a vascular injury. Okay.
okay, sir. Okay, sir.
And how will you manage? You will say, I will manage according to the ATLS. What is the first thing? That is the airway with C-spine immobilization. In the
Oh,
circulation, you did it right. That I
oh,
will pass two IV line cannulas. From one, I will start fluid resuscitation. From other, I will send for the labs and start uh, blood transfusion. I will send for the chest X-ray, fast scan, depending upon the availability.
okay,
And
sir.
now, once you have described the X-ray, when you were telling about the types, you're just supposed to tell the broad category names that there is an anterior-posterior, there is a lateral, and there is a vertical, or you can add there is a combined one. So there is no need to describe them because it will be
Oh,
one mark question. So you will be wasting your time in that part. Okay.
okay, okay, sir.
So regarding the management of the hypovolemic shock, you just told me that you will be doing just the very few initial things. Now, in this hypovolemic shock, in this scenario, the patient is having femur fracture, tibia fracture, there is a suspected abdominal
Okay,
injury, and there is urethral injury, and there is a pelvic fracture. So there are lots of things which you have to manage, and they all will
okay,
come in this answer. So you will
okay,
say that I will manage the patient initially with fluid resuscitation and blood to manage with the initial resuscitation, and I will apply the pelvic binder. Then for the stabilization of the long bones, I will apply splintage initially and consult with the orthopedic surgeon specifically for the pelvic uh, fracture as well. Regarding the renal pathology, I will consult with the general surgeon after fast scan, or if the patient becomes stable, I will prefer going for the CT scan, and I will also consult the urologist to manage the intra-abdominal bleeding because you don't know that what is the reason for that shock. So you have to encompass everything in your answer.
okay,
So
sir.
this
Okay,
is what they expect from you on the exam day.
okay, sir.
So what does the blood signifies? It's a urethral injury. Rest of things are good, but how will you confirm the diagnosis? This question is specific to the urethral injury. So you have to say that apart from CT scan, you will be going with the retrograde ureterogram and the antegrade cystourethrogram.
Okay, sir. Okay,
And also check that there are lots of other contraindications for Foley catheterization. Okay. So I've mentioned them in the video that I've provided you, so you can consult that as well.
yes, sir.
And regarding the pelvic fracture management, again, there is a summary at the end of the page number 20 on the Sala notes. So that you have to say. So first of all, the pelvic binder, after that transexamic acid, then if the patient does not respond, then you might be going with the surgical packing, that is through the lower midline laparotomy, followed with the early definitive surgery for the fractures as well as for the pelvic fracture. Now, if
Okay,
there is an associated colon injury, then you will be consulting the general surgeon, and for the urethral pathology, you will be consulting the urologist. So that will encompass your complete answer.
okay,
Okay.
sir. Okay, sir.
So next up, we have the lumbar spine fracture. So just read the scenario and then we will continue.
Okay, sir. Yes, sir.
Okay, so what will you do in this scenario?
So first, initially, I will follow the ATLS protocol, the ABCDE approach: airway, breathing, circulation, disability, and exposure. And would you like me to explain?
Okay. So just explain that how will you treat the hypotension in this patient with respect to the circulatory part of the ATLS protocol?
For the circulatory part, I will insert two large bore IV cannulas and start IV crystalline fluid resuscitation. Then withdraw blood for initial investigations like the full blood count, urea and electrolytes, RFT, LFT, then ABG and order blood for transfusion. Uh, yes.
So what is the type of shock which is present in this patient?
The patient will be having a hypovolemic shock, a spinal hypovolemic or a spinal.
Okay. So can you clinically differentiate between the neurogenic shock and the hypovolemic shock?
Yes, sir. In neurogenic shock, there will be a bradycardia. In hypovolemic shock, there will be tachycardia. In neurogenic shock, there will be in both the shocks there will be decreased blood pressure, and in neurogenic shock, the extremities will be warm. Hypovolemic shock, the extremities will be cold.
Okay, so what are the findings given in the CT scan?
There is an L2 compression fracture with the spinal cord compression. L2 spine fracture with compression.
Okay, so can you tell me about the scoring system used in the assessment of this patient? Just name them.
Mm, Sir, the injury comma scale. Mm, yes, I only remember those.
Okay, so what would be the clinical picture of this patient?
Mm, uh, Features. The patient will be having uh, spastic paralysis. If the patient will be having spastic paralysis and uh, hours of injury, and the neurogenic shock will occur within 2 months. There will be absence of bulbocavernous reflex in the spinal shock, but in the neurogenic shock, the bulbocavernous reflex is variable. The patient is having a spinal shock. The patient will be having a temporary loss of motor and sensations to the area below the level of injury. And mm, yeah, sir.
Okay, so why erection will be spared in this type of injury?
Sir, the screen just 1 second, sir.
Okay,
The screen is loading.
but just you can just continue with your answer.
Yeah, sir. Can you repeat the question, sir?
Okay, so why erection is spared
Uh,
in this
yes, sir.
type of lumbar spine injury?
Yes, sir. The S2, S3, and S4 will be intact. So hence, the erection would be spared.
Okay, so what is
Erectile, won't be any erectile dysfunctions.
okay, so what is Brown-Sequard syndrome?
In Brown-Sequard syndrome, there will be unilateral loss of um, position temperature on the area below the level of injury.
Okay, so what are the long-term complications and how will you manage them?
Syndrome has, sir, with regards to Brown-Sequard syndrome, no, sir.
No, long-term complications with respect to
Of
the lumbar fracture.
lumbar spine fracture. There could be various spinal injuries like the anterior spinal cord syndrome, the Brown-Sequard syndrome, posterior spinal cord syndrome. There will be loss of pain and temperature sensation on the same side. The prognosis is poor compared to the other injuries in the central spinal cord system injury in a patient who and the prognosis is better. And in Brown-Sequard syndrome also the prognosis is better. And in posterior cord syndrome, there will be loss of position sensation and ataxia. And there is a variable prognosis.
Okay.
Um,
So in this scenario, you just answered it very well that you will start with the ATLS protocol and you told very well about the hypotension. So this in this, the patient is likely to have the neurogenic shock.
okay, sir.
And the differences were okay. And there is one more thing that in this scenario, they can also test you for the difference between the spinal shock and the neurogenic shock,
Okay, sir.
because that question is also present in the cervical spine fracture scenario as well. Okay. So regarding,
Can we,
yes,
yes, uh, can we not say spinal shock in this patient?
no.
Uh, Only neurogenic shock we should say,
Till
sir.
now, because there is hypotension and bradycardia.
Okay, sir.
Okay, so up till now, it will be neurogenic shock, but it can later on be converted into the spinal shock.
Spinal.
Okay, because in spinal shock, basically, spinal shock is with reference to the loss of sensations and motor power of the body below the level of injury. But
Yes, sir.
neurogenic shock is with respect to the parasympathetic and sympathetic supply. Now,
Yes, sir.
sympathetic supply will be diminished and the
Oh,
parasympathetic will dominate.
overrides.
So,
Okay, sir.
like in normal scenarios, with hypotension, there should be tachycardia. It is a normal reflexive behavior. But
Yeah.
when it is bradycardia, it will definitely be a neurogenic shock scenario.
Okay. Okay,
So,
sir.
like that is the key point to note because that will be given in the form of a news chart. Okay. So it will not be like there is 110, 60 blood pressure and 82 pulse. Like there will be a complete chart that will be provided to you. So you
Oh,
have to go through those charts as well.
okay, sir.
Okay, so
Uh,
regarding the scoring system, we have the GCS, we have the injury severity score, and then we have the TRIS score and the revised trauma score.
yes.
So regarding the clinical picture, you described the features very well. And regarding the long-term complications, in the bones, there will be osteoporosis.
Oh,
In the veins, there will be DVT. In the skin, there will be pressure ulcers.
okay,
And
sir.
for the management, you will say that I will involve the multidisciplinary approach team.
Okay,
Okay.
sir. Okay, sir.
Okay. So next we have the crush injury scenario. So just read it and then we will start.
Yes, sir.
Okay. So what is the clinical picture of compartment syndrome?
The mm, The patient will be, sir, how to start, sir? Which one should I tell first?
Okay, so regarding the clinical picture of compartment syndrome, you will say that there will be worsening of the pain, there will be
Oh,
pain
oh,
despite analgesia, and there will be pain on passive stretch.
yeah, okay, sir. Okay, there will be pain on disproportionate to the signs, and there will be pain on passive stretching.
Okay. So in addition, there will also be paresthesia and loss of pulses, which are late sign. So what is normal compartment pressure?
The normal compartment pressure is less than 30 millimeters of mercury.
Okay. What are the indications of fasciotomy?
The indications of fasciotomy are if the patient is having any uh, if there is the patient is having if the pulse is less, um, if the patient is pulseless, um, and if there is any signs of acute kidney injury like myoglobin in the urine, where the urine dipstick test is positive, and
Okay. So what will be your treatment once you have confirmed that this patient has compartment syndrome?
sir, uh, can I use the ATLS principle again in this? Can I
No.
say that? No.
You can tell that I will manage the patient according to the ATLS, but the final answer would be emergency fasciotomy. Okay.
Okay, sir.
So in this scenario, they might initially ask you that how will you manage this patient? In
I
that,
will
you can tell
do.
that you can manage according to ATLS, but now the patient has developed compartment syndrome. So you will move with the fasciotomy. So
Okay,
why
sir.
this patient is likely to develop acute renal failure?
Because of the crush injury, there will be a release of myoglobin into the circulation,
Okay.
leading
So,
to acute renal failure.
okay, define rhabdomyolysis.
Rhabdomyolysis is a state of injury to the skeletal muscle, leading to a release of myoglobin into the circulation. When the obstruction is released. Mm,
Okay, so what are the different causes for rhabdomyolysis?
mm, Sorry, sir, I don't remember now. I think burns is a cause.
Yes.
Then crush injury is a cause. Then mm, yeah,
Okay, so what will be the management?
management will be fluid resuscitation with the name R. Then until the urea and creatinine normalizes, and if there is no the patient's condition regarding the RFTs does not improve, we can go ahead with dialysis, and if necessary.
Okay, so how you will do the alkalinization of the urine?
Mm, the I don't remember now, sir.
Okay, so can you tell me about the ischemia, ischemic perfusion injury?
Yes, sir. Yeah, during the accident, there will be if when the patient is having crush injury, there will be a compression over the injured part, and when the compression is removed, the or the occlusion is removed, there will be reperfusion into the introduction of the toxic metabolites into the either. So
Yes, I'm listening.
yeah, that's also skin creep.
Okay.
Along with there will be arrhythmias, hyperkalemia, hypocalcemia, hypophosphatemia. Uh, yes, sir.
Okay. So first of all, in this scenario, they will ask you that what could be the clinical picture. So we discussed it that there will be pain despite analgesia. There will
Yes, sir.
be pain on passive stretch, and there will be worsening of the pain. There will
Mm.
be associated swelling, tense, tender compartment. There will be paresthesia and pulselessness, which are late signs.
Yeah, pulse.
Yes. And after that, the normal compartmental pressure should be less than 30,
Okay, sir.
and normally it is 0 to 15 millimeter of mercury. And if it
Oh,
is more than 30, it will
that we must do
confirm
emergency
compartment
fasciotomy.
syndrome.
Yeah, okay, sir.
And indications for fasciotomy is compartment syndrome of the upper limb or lower limb. And the
Okay, sir.
treatment for this is fasciotomy.
Okay, sir.
Okay. So why acute renal failure develops is because one, there could be hypotension that will result into pre-renal damage to the kidney. Then intrarenal, there could be use of the nephrotoxic agents that is through the myoglobin that is released from the death of the muscles.
Yes, sir.
And after that, the post-renal, when the myoglobin gets deposited in the PCT, that is the proximal convoluted tubule, it
Yes.
will uh, cause an outflow obstruction. So these are the three reasons which are responsible for acute renal failure. Then the
Oh,
release of the myoglobin into the blood after the death of the muscle is rhabdomyolysis, and you have to know the reasons. Causes are very important. They
myelitis.
include the blunt trauma, massive burns, hypothermia, ischemic reperfusion injury,
Oh,
strenuous or prolonged exercise. Okay, so why and how we do the alkalization is through the use of sodium bicarbonate.
bicarbonate. Yes, sir.
And
Oh,
and what it does is that it will push the
yes, sir.
potassium back into the cells,
Back. Okay, sir.
and it will prevent the renal damage. Okay, and regarding the management, you will say that I will manage according to the ABC protocol. First of all, I will give the patient fluid resuscitation using good hydration, followed by use of diuretics, alkalization of the urine, and treatment of the electrolyte disturbances, which includes hyperkalemia. And I will monitor the patient using ECG,
Yes.
urine
Yes, sir.
output,
Yeah.
CK levels, and compartment pressure.
Okay, sir.
Okay. So this
Okay.
is about today's session. So any other questions or queries?
That's also some questions. Like I feel like I'm answering. I'm not answering broadly. I'm
Ye-
just answering a very small points.
Yes.
So next time I'll improve regarding the management and causes.
Mm,
I forgot
absolutely.
some causes and also manage.
Yes, the management points are very important because they usually carry high number of marks, like 3 to 4 marks are there. And in critical care, you will definitely be tested for the management of that scenario, be it a trauma case, be it a
Okay.
electrolyte imbalance case, or be it a abdomen or urology case, or whatever case. You will definitely be tested for the management, and you will be given enough time to speak it out in detail.
Yeah. Okay, sir. Okay. Uh, that's all.
Okay.
Mock.
Yes.
When will be the next mock, sir?
Next, tomorrow, if you are available.
Tomorrow. Okay, sir.
Okay,
Yeah.
so next we have the respiration. You can check the schedule. You can do the first three scenarios from
Okay,
the
sir.
respiratory chapter of the critical care.
Okay, sir.
Okay,
Okay. Thank you, sir.
thank you.